Brown. I'm joining you virtually from the Venice office, and I'm really pleased to be participating in today's summit. I think that you've organised an event which is really important to moving forward the agenda for better health in Macedonia, and I'm really pleased to be part of that process and to share with you some of the current thinking, evidence and approaches on why action on social determinants can help to achieve that objective. What I'd really like to share with you in the next 10 or 15 minutes are three themes. Why action on social determinants, why now, and what the opportunities and the implications are for how we move forward. I'd really like to start with a story. This is really for some people a fairy tale, in that it's something that they may aspire to but never achieve. And I think our responsibility and our vision should be to make this possible for all citizens in Macedonia to have this story of health and well-being. This is really the story of Snežana and Vladimir. They're born into families with a stable income, with employment where universal health and social protection is provided. There are good laws that are regulated to ensure that the houses that they're born into are secure and safe. And the local maternal and child health services are accessible and of good quality. They actually can attend preschool, and they have safe places for their parents and siblings to play with other children and families. As they grow up, they're growing up in a safe home. They attend a local school with health screening provided, and where there are anti-bullying policies in place provided by the schools. Their father, unfortunately, at the age of 6, experiences a period of unemployment, but because of family welfare policies, the family isn't thrown into poverty. Food supply is affordable, and there are good opportunities for participation in out-of-school activities to build social skills and to increase their confidence in everyday life. As they continue through education, they obtain good qualifications. They join a local company as apprenticeship where they're able to gain skills and expertise to help them in the job market. They're able to begin to save money and to rent a home. The area that they live in, there's good maintenance of cycle paths, libraries, parks and leisure facilities by the local council. It encourages them to have a more active lifestyle, and they meet and get married. So you can see how the fairy tale progresses. However, as is normal, there's a period of unemployment that they experience in their mid-30s, but again their savings from having a secure job and from social protection and welfare policies prevent them from losing their home and from preventing their families from experiencing deprivation. With the Ministry of Labour and Social Affairs and Ministry of Health, there are active labour market policies in place which enable Snežana and Vladimir to regain their training skills and enter back into the labour market. This allows them to maintain their pensions. They go for health checks which are offered and available by the local primary health care. Towards the latter stages of life, they have savings, they're in good health. They have regular checkups, and the local primary health care is accessible and helps them to manage their hypertension. Their spouse suffers illness, but it's managed with the support of good community nursing teams. Their personal capitals in terms of their family, their savings, their social skills allow them to pursue their interests and to stay involved in local society and projects. This is what we're aiming for in terms of the health and well-being for everybody in Macedonia, but we all know that because of decisions of other policy sectors, by the allocation of resources, and by different forms of discrimination that accumulate over a lifetime, some people will have this experience and some people in Macedonia will not. The question is, how do we make this possible for most people in Macedonia? What we've highlighted through the story of Snezhana and Vladimir is that across Europe there are common social determinants of health that influence not just how healthy we are, but how effective our health policies are, how effective our health interventions are. They include ethnicity, issues of poverty, employment, education, health and social protection. And in every country, including Macedonia, depending on where you're born, your ethnicity, the amount of money you have, the security of your employment, your access to education and the quality of that education, as well as health and social protection, will determine how healthy you are. So when we're considering, as we are today, health policies, we need to consider how our health policies are also addressing these other external factors that we call social determinants of health. And what I'd like to do in the next maybe 5 minutes is to share with you some of the very key policies for health that are actually outside of the health sector, but where we need to have better connections with. Let's start. A good start in life. What does the evidence tell us? It tells us that relative poverty in childhood influences health and other outcomes, not just in the early years, but over the whole of life. We know that there's a strong association between under-5 mortality rates and level of deprivation. So in addition to providing good child and maternal services, we also, if we care about the health of children, need to work with other sectors to reduce deprivation. Where children live in poverty, the amount of money available to assure basic needs are met is low, and this means the ability to secure a healthy start in life is challenged right from the start. So what we can see here is that poverty reduction strategies are actually health strategies. They're just not called that. And we need to be smarter and more effective in how we jointly work with other sectors on common agendas that improve health and the determinants of health. We can see here how maternal education is a strong indicator of child nutritional standards. So in addition to us providing advice to mothers on nutrition, we also need to be aware that the level of a mother's education may influence their knowledge and their skills, as well as their income levels, to be able to provide quality nutrition for young children. And you can see here that level of education comparing mothers with no or primary level to mothers with secondary or higher level, whether it be for chronic malnutrition, acute malnutrition or underweight, there is a difference. So you can see the difference within Macedonia, but also with comparable countries. I mentioned already how poverty influences outcomes. But actually poverty itself is determined partly by the labour market and by social policies. And we can see here how social policies and labour market policies can actually mitigate the effects of poverty and improve the early start in life. So whilst we may be focused on clinical issues and primary healthcare services, we do need to be working with our other sectors to reduce poverty and to lobby for good welfare policies and social policies for children and families. We know here that social protection matters in reducing child poverty. Here we can see how social transfers before and after influence the poverty rate for children. So ministries of health can play a key role in lobbying for and supporting ministries of labour, social affairs in adequate social protection that reduces child poverty. That would be an intervention, maybe not a traditional intervention for health, but one that would actually improve the health of children in the early years of life. If we move along and we know that we are concerned with non-communicable diseases and the risk factors for non-communicable diseases as a major health challenge, but actually we need to think broad in how we consider and design our non-communicable disease strategies. If we look here at the evidence, long durations of involuntary employment, and we know that in many countries of the region, unemployment for young people is about 50%. Where we have that level of unemployment for 3 years or more, particularly in young men, we will see heavy drinking at later stages of life. What that tells us is we need to have a much more life course approach to issues of NCD prevention rather than single interventions at primary healthcare or hospitals at certain stages in life. Those who experience long-term unemployment before the age of 33 are more likely to report risk-taking behaviours than those who have not experienced unemployment. So when we're seeing higher rates of accidents, suicides, mental health, depression, substance misuse, we need to trace it back and we will see the link to unemployment. So when we're designing our NCD strategies or our alcohol reduction interventions, we also need to address the issues of employment. Poor mental health, we see, is more prevalent among workers with non-fixed or temporary unemployment. And we know that there's been a massive increase in the contractual basis of employment across the European Union in the last 10 years. This is why the health sector needs to be a partner with other sectors in promoting policies that benefit health, but that also have other outcomes. Here we can see, and I've highlighted, as you well know, the impact of the financial crisis on work and worklessness. What we can see here is actually a time bomb waiting to explode in terms of alcohol and NCDs in later life that stems from work and worklessness. Now, ministries of health are a major employer. They employ people in all kinds of sectors, both professional and administrative and service support sectors. And we know that ministries of health can then be part of active labour market programmes that provide apprenticeships, as well as then using their services to provide outreach to young people, mental health services in the community. So this is the way that ministries of health and health community can actively work on social determinants jointly with other sectors. We hear so much today about bad behaviour. Drinking is to do with people who are ignorant, who don't take responsibility. But in fact, the evidence tells us a different story. The evidence tells us that poverty, more than behaviour, is the biggest predictor of early onset of disease and premature mortality. So the question is, how are we using our poverty reduction strategies, our social inclusion strategies, to integrate health measures into that and to consider health as an outcome? We also know that the comorbidity of non-communicable diseases in all European countries cluster in the most poor and vulnerable in society. So therefore, if we're really serious about reducing the burden of non-communicable diseases, we actually have to get better at working with our other partners in other sectors to reduce poverty and to develop joint interventions that reduce vulnerability and poverty. We know that an ageing population is a big issue across the whole of Europe, both in terms of the sustainability of health and social care systems, but also in terms of demographics, in terms of the ability of older people to work, contribute to a tax base and savings. What we know so far is that men are dying earlier, but women are living longer in poorer health. And we can see that this doesn't start just in later life, it starts in early years. So people who are exposed to more insecure housing, poorer health, lack access to good health and social protection services, experience more periods of economic uncertainty in their life, it accumulates so that in later years they have more sickness that requires a lot more intervention. and that rate of sickness is spread out of more years. This is something that economically we can't afford. It's unnecessary in terms of health and human rights. So it's something that we need to be, let's say, a little bit more creative in how we handle, and we need to be addressing early onset of disease, not just at retirement, but through the whole life course. Keeping people healthier for longer means starting in the first years of life. There is an issue about universal access to health services and how universal access delivers equity of outcomes. The last example I show you in terms of health in later years, I used to illustrate this in terms of universal access. Improving health for all means we need to address the different hurdles faced by different population groups to access services and to deliver improved health outcomes. So providing universal access is what we're saying doesn't necessarily mean that we get universality of outcomes. And why is that? This is quite a typical example, not just for Macedonia, but for Europe generally. Rural populations have a problem in accessing services that are provided because of transport costs or because of poor transport infrastructure. In some cases, employer contributions are not paid, so there's an additional cost or lack of coverage. In some cases, there's actually a lack of services. In some cases, services are provided, but they're not provided in a way for people who may be housebound in terms of community services. And in some cases where services are there and contributions are paid or have to be assessed, the forms that you need to fill in are not easy to follow. And therefore, these all are examples of hurdles that get in the way in terms of people accessing services even if they are provided. And we need to look at these factors and say how many of them apply and how many of them are contributing to the differential outcomes of health services. Sometimes the consequences of policies or events, social and economic events, produce health problems. Let's look at this example. In many countries at the moment, or in the recent past, we have agricultural reform, led by ministers of agriculture, economy. And what we see is a 17% increase in grain yield, which is great, that was the aim. However, 7% increase in rural unemployment among small-scale agricultural farmers and labourers, outward migration of young people and families because of the changes in employment opportunity, an 11% rise in self-harm rates in young people 15 to 24 years. Now this is another reason why we need to be working on social determinants, because actions of other sectors that don't consider health can produce these unintended consequences. And this is a scenario that is real. Most countries would be able to associate with it. And what it means is that our approach to managing vulnerability and exclusion needs to be a lot more sensitive than it currently is. If we just focus on specific vulnerable groups and we're not looking at what's going on in other policy sectors or the impact and measuring the impact of the social and economic changes, we're not able to respond as quickly. So what we've been looking at is why social determinants and why now in terms of the big differences both between and within countries and that accumulate over the life course. But action on social determinants isn't just something that improves efficiency, it improves our health outcomes, but it also contributes to the attainment of other societal goals. Let's look at this from a point of economic growth. Where we have shortfalls in health that are avoidable, these we call inequalities. The losses to health reduce labour productivity by about 1.54% of GDP each year, and they account for about 15% of the total cost of social security benefits. They're losses that are avoidable. So your ministers of economy and labour and growth are very interested in this as a way of reducing health inequalities. In terms of inclusive development and regional cohesion, we know that the burden of non-communicable diseases is clustering in poor and most vulnerable in society. They also cluster geographically in different sub-regions within a country. Here, in these regions, we have losses of human capital, well-being and community cohesion. These are constraints to inclusive development. Any country that's following EU accession and that's following social cohesion, this is a major issue, how health can contribute. By reducing inequalities in health, we can contribute to reducing these differences in within-country cohesion. Demographic trends and an ageing population. Well, this is really important given what's happening in terms of the ageing trends in Europe. Good health raises the probability of working in the first place, and it emerges as the main, if not the sole, determinant of labour supply by older workers. This is really significant given the demographic transition in Europe now. That's why we need to be investing in the health of an older population now and through the early years. We also know that for public health effectiveness and health systems performance, reducing inequalities would account for an improvement in healthcare. 20% of the total cost of healthcare in middle and high income countries are to do with avoidable losses due to inequalities in health. So you could improve healthcare performance and efficiency by 20% by reducing inequalities. Now that's what the evidence tells us. They're the rationale about why we should invest and why we should work on social determinants and some of the policy domains that we may want to work on. But we all know that the reality we're working in, the political context, the policy-making context, has got competing agendas, diverse interest groups, and multiple factors. However, we have at this moment in time a unique opportunity for improving how we work on social determinants. Why is that? Because at this moment in time there is a convergence of interest on the social determinants of health coming from all different parts of organisations and the globe. We have the MDG saying that actually we could have improved our performance by acting in a more coherent manner on the underlying determinants of health and in a more integrated approach at the local level. We have a new report on health inequalities in the EU just about to be published by DG Sanko. UNDP have just brought out in 2013 a discussion paper on addressing the social determinants of non-communicable diseases. That's not a health, that's UNDP. We've got the WHO Euro review of social determinants of the health divide. We've got an instrument through The Economist worldwide talking to financial and economic leaders on why, for richer for poorer, growing inequality is not inevitable, but it is a major challenge for progression. And in the Southeast European region of Europe, we have the Western Balkan Investment Framework, talking about the need to address inequalities in the social determinants of health. This is a unique time, a convergence of interests, of opinions. So despite the usual divergence of opinions and conflicting views, here we have a unique opportunity to move forward with these agendas, with all these agencies behind us, and we need to take it. We need to take the opportunities to make progress. And here are some super examples of how we can do it. I'm not going to talk about all of them, maybe highlight a few. We have for the first time, if we take the second point, 4 health measures that are integrated within the Southeast Europe 2020 growth strategy. And this is a growth strategy that your Ministry of Economy will be responsible for reporting on annually. And 4 health measures are in there in terms of how they contribute to inclusive growth. That's the first time Ministers of Economy are going to be held responsible for delivering on improvements in health. We need to be able to step up to the mark and support that process. On the counter side of that, we need to be acting on social determinants to safeguard health in the light of threats. And we know that, let me pick 2 there, that in a recent EU social spending review, health is seen as a cost. We need to challenge that. We've just looked at the evidence in the last 10 minutes that show how health contributes to growth and development. We need to challenge it by demonstrating that. Unfortunately, we're not so good at articulating health and action on the social determinants of health in broader development frameworks. And an example of that is if we look at the country strategic papers for EPA 2, health is not very prominent or very well articulated. But we do have an opportunity to redress that in the next round of drafting of those papers. And this is what we want our policies to do. Well, actually, it's simple. We want to improve health for everybody, but we want to accelerate the progress for those who have the least health and health opportunities. How we do that requires a different way of thinking. We know that today's event is looking at the type of policies we need to improve health in Macedonia. Well, we have 3 different types of policies that can do that. The obvious one is the specific health policies. Our policies for NCDs or for universal health, for vaccination. And in those we need to involve other sectors and partners and to coordinate. However, there are also public policies such as labour market policies, education policies. These are also policies where health can benefit. In this we need to be a partner and we need to participate and contribute. And then there are broader development frameworks for growth and development, social inclusion, cohesion, poverty reduction. Here we need to show how health contributes to poverty reduction, to social inclusion. And in these our role is much more as a person to shape and to partner in the development of those. Have we got the right evidence? Have we got the right skills? The right mechanisms in place to do that? I hope that today's forum will go on to discuss that, and I hope that we will have an opportunity to work together to strengthen those where you feel they need to be strengthened. Thank you very much.